When people hear the words genetic testing and autism, many assume it is about finding a cause, assigning blame, or trying to change who someone is. That is not what this conversation is about. Genetic testing in severe autism is not about fixing a person. It is about understanding the body, protecting health, and making sure care is informed instead of guess-based. Most individuals with severe autism are offered very limited genetic testing, if they are offered any at all. In many cases, testing stops after early childhood or never happens in the first place. When testing is done, it is often restricted to chromosomal microarray and sometimes Fragile X testing. These tests matter. They look for large changes in DNA, such as missing or duplicated pieces of chromosomes. These kinds of changes can absolutely cause autism, intellectual disability, seizures, and other medical issues. But they only tell part of the story. Many of the genetic conditions linked to severe autism are not large deletions or duplications. They are small changes in single genes. These changes cannot be seen on chromosomal microarray. If testing stops there, those diagnoses are missed entirely. This is where sequencing comes in. Whole exome sequencing and whole genome sequencing look much deeper. They analyze genes involved in brain development, synapse signaling, seizure regulation, metabolism, and nervous system function. These tests have transformed what we understand about severe autism, especially in individuals with absent speech, intellectual disability, epilepsy, hypotonia, or regression. And this matters because many people who are labeled as idiopathic autism actually have identifiable genetic neurodevelopmental conditions. Some of the most commonly misdiagnoses include conditions linked to genes like SYNGAP1, SCN2A, SHANK3, MEP2, ADNP, CHD8, DYRK1A, and POGZ. These conditions are not theoretical. They are increasingly recognized in clinics and research, yet many families never hear these names because testing never went far enough. These conditions are often missed for very practical reasons. Chromosomal microarray cannot detect single-letter DNA changes. Testing was done 10 or 15 years ago before sequencing was standard. Results came back as uncertain and were never revisited. Symptoms were attributed entirely to autism without looking deeper. There are also diagnoses that are missed because they do not look obvious on the surface. Take P10-related autism as an example. P10 testing is often only ordered when head size is dramatically large, but not everyone with a P10 mutation falls outside the most obvious range. Some individuals were never measured consistently. Some were missed because head size was never considered important once autism was diagnosed. This matters because P10 mutations carry real cancer risk and require medical surveillance. Missing that diagnosis is not neutral. It has consequences. Rett spectrum disorders are another example. Many people think Rett only looks one way: loss of hand skills, hand wringing, clear regression, but atypical presentations exist. Some individuals lose language slowly. Some never develop hand stereotypies. Some males and mosaic females are overlooked entirely. Without MECP2 testing, these individuals may be mislabeled for years. Metabolic and mitochondrial conditions are also commonly missed. These are not part of routine autism testing, but when there is regression, extreme fatigue, recurrent illness, unexplained vomiting, or involvement of multiple body systems, these conditions should be considered. Some of them are partially treatable. Some require specific precautions. So the question becomes, if genetic testing does not change the autism itself, why does it matter so much? Because a genetic diagnosis changes care. It changes how doctors monitor health. Some genetic conditions carry high seizure risk, even when seizures are not obvious. A diagnosis may prompt EEG monitoring instead of waiting for a crisis. Some conditions affect breathing, heart rhythm, kidney function, or cancer risk. Without a diagnosis, those risks are often invisible. It changes medication decisions. Certain seizure medications can worsen symptoms in specific genetic epilepsy syndromes. Without genetic information, prescribing becomes trial and error. With it, care becomes safer. It changes therapy priorities. Instead of chasing normalization or unrealistic academic goals, care can focus on communication access, safety, mobility, feeding, sleep, and daily functioning. For some conditions, early AAC access is critical. For others, managing hypotonia or sensory regulation takes priority. It protects families from being pushed into harmful or ineffective treatments. When there is a biological explanation for severity, it becomes harder to blame parenting, effort, or compliance. It draws clear boundaries around what is reasonable to expect. It also affects access to services. A named genetic condition can strengthen eligibility for Medicaid, SSI, waivers, respite, home nursing, and higher levels of supervision. In some systems, autism alone is not always taken seriously. Autism with a recognized genetic syndrome often is. It opens doors to research and clinical trials. Many gene-specific autism conditions now have natural history studies and targeted research. Without a diagnosis, individuals are excluded from these opportunities, and it changes the emotional landscape for families. For many, a diagnosis ends years of wondering what they did wrong. It reframes severity as biology, not failure. That matters more than people realize. So, how do you advocate when testing is minimized or denied? You advocate by being specific. You do not ask, should we do genetic testing? You say, I'm requesting chromosomal microarray and Fragile X testing. If those are non diagnostic, I'm requesting whole exome sequencing with reanalysis. You frame it as medical necessity, severe autism with significant functional impairment, absent or minimal speech, intellectual disability, seizures, regression, or medical complexity. These phrases matter. They trigger guideline-based care. You anchor your request to standards of care, not emotion. You are not asking for curiosity testing. You are asking for appropriate medical evaluation. And if a provider refuses, you calmly ask them to document that genetic testing was requested and declined and the reason for the decline. That request alone often changes the outcome. If insurance or Medicaid is the barrier, you ask for prior authorization and appeal. Many initial denials are overturned when severity and medical necessity are clearly documented. If testing was done years ago, you request updated testing or reanalysis. Exome data can be reinterpreted as science advances. Diagnoses are often made years later without new blood work simply because knowledge has changed. This is not about chasing answers endlessly. It is about making sure care is informed, preventative, and aligned with reality. Genetic testing does not define a person. It helps the system respond to them appropriately. If this information helps even one family avoid years of missed care, unnecessary blame, or preventable medical risk, then it matters.